I tell people, you're paying for this. It's not like this is an emergency mommy makeover. Like, you're putting your own money into this. So let's make sure that you get out of it what you want. This is a question I get a lot, and I'm curious, actually. I want to know what you do in your practice, because I think everyone's a little different. There's advice from, anesthesia group and all this stuff, like, National Anesthesia Society, whatever. But so this patient says, I've lost weight on Tirzepatide. How long should I be off of it before I plan a mommy makeover or mommy takeover? So again, for people that haven't heard of Tirzepatide or Ozempic, Semaglutide, these GLP-1.
Where have you been if you haven't heard of any of the GLP-1s?
The skinny shot, whatever people call it.
In a cave under a rock.
Yeah, it's wild. I think it's really changing even our field. I think as people are on this more and more, we're going to see it, especially as it becomes more widely available, comes into oral form that's effective. I think we're going to see more and more patients coming in with all these skin issues, because in the end, they're not going to be able to lose that skin. But what do you tell your patients, Sean? Like, what's your guys' kind of protocol in terms of stopping it, restarting it, all that?
Yeah. So for the anesthesia groups and for myself in the area, it's a minimum of a week hold. My preference is 2. I know that they kind of start at a week, and then some people are kind of scooting up. But a minimum of a week goal 2. Yeah. What about you?
And I think when I first started, it was like 4 weeks, because I was like, I'd be ultra conservative. And like I said, at the Academy of whatever anesthesia, they came out and said, hey, like, you can do it whatever, 2 weeks or whatever. So we're between 2 and 4 weeks, depends on the patient and some other factors. But mainly we do it 4 weeks because that's when our patients come in for pre-op. They're coming to see our nurses. So we just try to have all the medications, keep it consistent for them. Say, hey, for the next 4 weeks, we're going to hold you off of it. And then afterwards, we hold it for the same thing, about 4 weeks. And the main reason for that is for wound healing, because a lot of things that I see with patients when they're on these medications, if they're not properly getting the proteins and all the nutrients, they're not eating, they're literally starving themselves because they're not being managed. Someone just prescribed it for them on the internet and sent it to them. So these patients, literally, I've checked some of their albumin, their pre-albumin is like crazy low, and you're not going to heal anything in your body if you just can't have the stuff to heal it. And so that's why I stop it actually a little bit earlier, is because I want them to have a little bit of an appetite to be able to eat enough. Yeah. And then, we do supplement that with our nutritionist, and then she'll kind of work with them and all that. But
yeah, I mean, especially post-operatively for a tummy tuck, number one, like one of the major side effects of all of these can be low energy. It's like their energy is already 0, right? They're just like on E for weeks anyway. You don't need anything making that worse. And they don't eat a ton anyway from the muscle repair. I don't know what it's like in your practice, but it's like I'll have patients lose like 20, 30, 40, 50 pounds post-op because they're just not hungry, because there's less space after the muscle repair. It's like they're like, I eat a cracker and I'm full to the brim. So how are they supposed to get the protein that they need as the building blocks for healing if they're not hungry? And then you're adding a medication that it also makes you not hungry. It's like you will literally starve yourself to a wound complication is what will end up happening.
For sure. And it's a real thing. So I think for sure in plastics especially, we're creating all these large incisions and wounds, like you said, especially tummy tucks, extended tummy tucks, fleur-de-lis. You have to heal those wounds. And I think, as plastic surgeons, we dealt with that in training. We see people who had poor protein levels, a lot of patients that have decubitus ulcers, who may be paraplegic, quadriplegic, so they're kind of bed bound essentially. They're not getting enough protein. They're not getting, obviously, exercise out of the bed. So they're just kind of wasting away. And we've seen these wounds and complications. And so the first thing we do is, hey, let's check a pre-albumin, let's check their, all their labs. Let's see where their nutrition status is at. And then let's correct that before we do surgery, because we don't want to create more issues, expose them to more complications before they're tanked up. So, and I think this goes across the board. So not just in protein and things and levels, but like you kind of mentioned earlier about BMI, for a long time, like, my requirement for surgery was, let's get you to BMI of 30 and under. And then I've lowered it to 28. But we started our wellness clinic. And I think that's been a huge thing, because I don't tell patients they have to achieve a certain goal without being able to help them. Right. And so before I'd be like, oh yeah, go see your primary and just figure it out. But now it's like, no, like we will help you, because I know that your results can be better. It can be safer for you. There's data to show that, as your BMI is closer to more of your goal weight. I don't use ideal weight, but a goal weight, I think you'll have better healing. You'll have better results. And, you know, like I tell people, you're paying for this. It's not like this is an emergency mommy makeover. Like you're putting your own money into this. So let's make sure that you get out of it what you want, you know? And so that's been what we've been doing.
Yeah. Although it's like, I do see patients from time to time, right? They've already lost weight. They've already like fought and kicked and scratched to get themselves to like 33 and a half. And they're like, listen, doc, this is it, buddy. Like, I'm not getting any lower than this. Because I talk to them about that. And it's like, for everybody, I always tell them that my cutoff for surgery, for surgical risk, is 35. My cutoff for like optimal results is in the 20s. So I have a serious discussion with them of like, you know, you can have the surgery now, or we can get you settled in and then figure out a way to get you where you want to be. And sometimes they're like, you know what? I'm paying good money. I'm going to take a lot of downtime. Let's get to where, you know, let's get to 185 pounds. Let's get to where we want to be. But especially for like the golden year glow ups, right? It's like, but it's like 62. And she's like, Sonny,
that ain't happening.
This is as trim as I've been in the last 20 years. This is what it's going to be. So let's just make it happen, which, you know, as long as they understand.
Exactly.
You know, true informed consent, as long as they understand, I'm like, sure, let's do it. That's what we're here for.
No, I love that. I love that.